Good morning.
That's medium, yeah.
All right, okay. Yeah.
Okay,
begin.
perfect. Okay, it's my pleasure to introduce Dr. Adriana Dejman. Dr. Dejman is an assistant professor of clinical medicine in the CATS Family Division of Nephrology and Hypertension at the University of Miami. She earned her medical degree from the Universidad Central de Venezuela Escuela Jose Maria Vargas in 2010, followed by internal medicine residency from 2012 to 2015, and nephrology and hypertension fellowship from 2015 to 2017 at Jackson Memorial Hospital, University of Miami. Dr. Dejman joined the faculty after fellowship and was awarded an International Society of Peritoneal Dialysis grant to train at the University of Alabama in Birmingham, further advancing her expertise in peritoneal dialysis. She briefly left to Texas and since returning to the University of Miami in 2019, she has led the growth of its peritoneal dialysis program, now the largest in South Florida, and established a remarkable biorepository for proteomic and metabolomic analysis of peritoneal membrane tissue. A strong advocate for patient education and home-based dialysis therapies, Dr. Dejman focuses on improving access, outcomes, and quality of life for patients choosing peritoneal dialysis. It is my great pleasure in welcoming Dr. Dejman to the stage to kick off our 2025 Grand Rounds presentations.
Great, thank you for that introduction. It's my pleasure to kick off the Medicine Grand Rounds series with the topic that passions me the most in nephrology, which is peritoneal dialysis. So we'll be shedding a little bit of light on recent advances in understanding the peritoneal membrane. I don't have any disclosures. The objectives of today's talk is to describe the structure and transfer properties of the peritoneal membrane and their relevance to peritoneal dialysis, to identify key factors that contribute to peritoneal membrane alterations over time, including the impact of dialysis solutions and clinical complications. And lastly, to apply knowledge of peritoneal membrane physiology to optimize dialysis prescription and improve patient outcomes. But before we throw ourselves into talking about these advances in understanding the peritoneal membrane, let's talk a little bit about what peritoneal dialysis is, commonly referred to as PD. It's a home-based kidney replacement therapy that uses the peritoneal membrane as a semi-permeable bidirectional barrier to remove or depure waste products and water from the bloodstream through exchanges between the peritoneal capillaries and the dialysate that is instilled in the abdominal cavity. It carries with it many advantages, not only the ones that I note here. For example, it empowers a patient, it gives them autonomy, it has a high profile safety, improves quality of life, cost effectiveness, it's cheaper than in-center hemodialysis, and it preserves the residual renal function more than in-center hemodialysis. It's also linked to better outcomes post-transplantation and other things such as travel is much easier for the patients. It also increases shared medical decision-making between the patient and the nephrologist. And the way that I practice peritoneal dialysis and what I tell my patients is that PD should adapt to them, not them to it. So I find that to be a very important and something to consider about PD. Nevertheless, despite everything that I'm saying right now, it's still unfortunately underprescribed. It only accounts for around 15% of the prevalent end-stage kidney disease population in the United States. And we could have another whole talk about why this is happening, but it's out of the scope of today's talk. So the components of the peritoneal dialysis system includes obviously the lifeline of the patient, which is the access, a PD catheter. It's called a tank pop catheter. The peritoneal membrane, of course, and its associated vascular supply, and PD solutions. And up to date, we still use mostly glucose-based solution, and it's almost synonym to what peritoneal dialysis is to date. How does peritoneal dialysis work? Well, the patient is going to fill their abdominal cavity with this glucose-based or non-glucose-based solutions. They leave it in for a couple of hours to dwell when all of this exchange is going to be occurring between solids and ultrafiltration, and then it's going to be drained. The patients have the option to do it manually, which is what we refer to as continuous ambulatory peritoneal dialysis, versus a machine overnight while they're sleeping. It's called automated PD. These three steps is what we refer to as an exchange, and typically a patient will require anywhere from 1 to 6 or more exchanges in 24 hours. So the peritoneum as a dialyzing membrane. Obviously, the peritoneum is a critical component of PD. It's formed by visceral peritoneum, mesenteric and omental surfaces, and parietal peritoneum. And even though the parietal peritoneum is the less dense or accounts for the less extension of the entire peritoneum, it's where the vast majority of all these solute exchanges occur. It has extensive blood supply, and like I mentioned prior, it's semi-permeable and bidirectional, which allows this to happen, moving from higher concentration gradients to lower concentrations by the membrane. So by diffusion and convection is how it occurs. So if we look a little bit deeper into the peritoneum, the components of the peritoneum itself is constituted by the mesothelial cell layer adhering to the basement membrane, the interstitial space, connective tissue and fibroblasts, and lastly, the capillary endothelium. And if we look further into the capillary endothelium, the number of capillaries and vessels recruited once they're placed in contact with the dialysate solutions is what we call effective peritoneal surface area, because that's what's going to be determining how much dialysis will be happening or occurring. Now, clinically, there's a hypothesis to explain how all of these solutes are transported in water, of course. It's called the 3-pore model of peritoneal transport. It has identified 3 sizes of pores in the peritoneal in the capillary of the peritoneal membrane. The ultra small or aquaporins, it's only permeable to water. It's very low density, accounts for 3%. However, it provides around 40% of total ultrafiltration in the dialysis. Followed by the small, this is a major conduit for solute and fluid ultrafiltration, around 60%. It's the highest in density. This is sodium, potassium, etc. And then we have the large that are where the macromolecules like beta-2 microglobulin will be moving from one side to the other, also very low density. So the efficiency of PD as a life-sustaining kidney replacement therapy relies on the integrity of the peritoneum. However, unfortunately, it may decline only after a few years after starting therapy. And understanding the peritoneal membrane and mechanisms of UF may help individualize the PD prescription and improve outcomes and quality of life in these patients, which is ultimately what matters the most. So what do we refer to as, and why does this bioincompatibility occur? Well, as you can imagine and infer, high glucose dialysate leads to generation of glucose degradation products and advanced glycosylation end products. And these, plus glucose itself, all lead to cytokine production, contributing to chronic inflammation and fibrosis progression, compromising the peritoneal membrane integrity. Not to mention systemic side effects like hyperinsulinemia, hyperlipidemia, obesity, and hyperglycemia. So if you're a visual person, this is what happens. In box A, you can appreciate a patient's biopsy of the peritoneal membrane once a catheter was placed, meaning before starting the therapy itself. You can see the mesothelial cell, the interstitium, and then followed by the capillaries. And that same patient was biopsied 5 years later in box B, where you can appreciate how much of structural alterations, loss of mesothelial integrity, submesothelial fibrosis, neoangiogenesis, vascular proliferation, all after 5 years on being on peritoneal dialysis. It's not only the glucose itself and the byproducts that lead to this local inflammation and change in the peritoneal membrane, it's also systemic or local inflammatory episodes, particularly episodes of peritonitis, the systemic inflammatory status that end-stage kidney disease itself is, and then that will compromise the mesothelial cell integrity, changing it to epithelial mesenchymal transformation, and also fibrogenesis. Obviously, vascular and fibrotic changes will occur, and the longer the patients are on PD, the more of these changes will be incident. So why does this matter? Because clinically it leads to ultrafiltration failure, which by definition is the incapacity or inability to remove appropriate amount of fluid from a patient on dialysis. So in a nutshell, this continuous exposure to bioincompatible PD solutions plus episodes of peritonitis lead to inflammation of peritoneal membrane, further leading to fibrosis and angiogenesis, and finally expressing clinically with ultrafiltration failure. We all know that volume overload is not good. It leads to increased hypertension, left ventricular hypertrophy, inflammation, heart failure, compromising residual kidney function, atherosclerosis, and further increasing cardiovascular morbidity and mortality, which is a #1 cause of death in dialysis patients. So what can be done? What is being done to reduce the membrane damage? First, we must understand the peritoneal membrane to know what to target and how to target it. The peritoneal membrane is like a fingerprint. It's unique to each patient, and there's nothing that we can do before starting the patient on dialysis to sort of try and guess what type of membrane they'll have. When I say what type of membrane, we usually refer to high transporters or low transporters, and that's what's being looked at. Part of it is genetically determined, and clinically, the way that we can start to see how these membranes will behave is doing something that's called the peritoneal equilibration test. It's a standard test that we do 6 to 8 weeks after a patient is started on peritoneal dialysis. We also know that we must reduce inflammation, so both systemic and local, treating comorbidities, keeping diabetes in check, and then local, trying to avoid peritonitis episodes or treating it promptly. We take patient education very seriously, particularly to avoid peritonitis episodes. If the patient does have peritonitis, after the episode, they will be retrained, or if they're hospitalized for a certain period amount of time, they're retrained to minimize this risk. Also, reduce glucose exposure. So how? Something I have not mentioned is that in the PD glucose-based solutions, we have 3 tonicities, lower, medium, and highest tonicity of glucose concentration. And we usually practice with the less percentage of glucose as much as we can, unless of course clinically the patient requires much more ultrafiltration or volume removal, in which case we use for a limited amount of time the highest tonicity, usually inpatient, hospitalist, heart failure, exacerbation, but we try to avoid this to be done on a daily basis. Like I said, prevent and treat peritonitis promptly, and then peritoneal rest. That's a term that is referring to the fact that patients, if they are transitioned from peritoneal dialysis to in-center hemo for around 6 months, these changes in the membrane can be undone. This was a study done in Japan where they took a lot of patients and did this and biopsied them thereafter and did see that there was reversal. So this is something to take into consideration. Sometimes if the patient's having issues or if they're burnt out, maybe they can take a break and then go back to peritoneal dialysis. And then medications. I want to take the opportunity here in internal medicine to let you guys know how important it is for us to place the patients on RAS inhibition, despite the fact that they're already on dialysis. We use it for the to reduce fibrotic changes, angiogenesis, like we use it in cardiovascular disease. So don't be estranged if you see a patient on dialysis on RAS inhibitors. It's on purpose. It's to protect the peritoneal membrane over time. So the genetic determinant of the membrane function. A couple of studies have been done, and we know that 20% of the variability in peritoneal solute transport rate will be genetically determined. In the largest study called the BioPD, around 26,000 participants, they identified loci with suggestive association with peritoneal solute transport rate. In another study, the genetic variation of aquaporin-1 gene encoding water channels they saw that it influences the expression and density of water channels. In this study, they enrolled around 1,800 patients, Europe and Asia, and they did identify 2 or actually 3 types, 3 genotypes that will determine what type or how functional the aquaporins will be. The TT genotype, the CC genotype, and the CT. And you can appreciate the red line is a TT, they do worse. 14% of the cohort fell under this type of genetic variant, and they do worse clinically because it has more, it's correlated with more ultrafiltration failure and all the clinical consequences that's linked that I mentioned before, cardiovascular mortality, etc. So what else can we do clinically to combat all of these PD solution glucose-based associated toxicity? We have commercially available glucose-sparing dialysate solutions. Currently in the market, we have 3. They're called the novel neutral or physiological pH and low GDP fluids. They use lactate or bicarbonate as a buffer. Icodextrin, which is the one that we most commonly use. It's a starch-derived glucose polymer, works a little bit different than glucose, obviously, but it's an excellent alternative. And amino acid-based PD solutions, which uses the 1.1% of amino acid as a gradient as an osmotic gradient. However, what's the problem with these glucose-sparing dioxide solutions currently available? Well, cost is a big deal. Icodextrin is really the one that we use the most, and to be able to get it approved, we do need to show and prove the need for it. For example, in patients who have fast transporting membranes and are getting problems with ultrafiltration. And then we also use amino acid-based PD solutions in patients diagnosed with malnutrition, diagnosed by serum albumin less than 1.6 for 3 consecutive months. However, because if we were to, it's only allowed to use one exchange in the entire cycle of the PD prescription, because otherwise it would lead to problems with ultrafiltration and proper solute clearance. And then glucose-free dialysate solutions that are under development, we have a couple. I mentioned here hybrid branch polyglycerol, or HPG, which is a biocompatible polymer. It's water soluble. However, it's only been tested in a lab with rats, but clearance was comparable and UF was preserved significantly better. Nevertheless, this component, HPG, is excreted renally, so it may pose health risk in dialysis patients. Also looked at, interestingly, steviol glycosides, yes, from the sweetener plant stevia. It has an osmotic capacity similar to that of glucose. The concentrations of angiogenic factors were not upregulated by this one. However, safety and clinical efficacy require more investigation. And then lastly, the one that I will describe a little bit more because it's exciting in the field, Silacor, referred to as the magic elixir of PD. It's the one that's been advanced the most. It's currently a non-inferiority ongoing phase 3 clinical trial. So what is Silacor? Silacor is a solution that uses a combination of L-carnitine and xylitol, which are osmoprotectives, and glucose, but much less concentration. The Elixir study is the ongoing phase 3 randomized controlled blinded outcome assessment study comparing Silacor versus standard glucose-based regimens. The way that they're doing it is with continuous ambulatory peritoneal dialysis. Their goal is to recruit 170 patients, randomizing them 1-to-1 to receive Silacor versus their usual therapy with glucose-only PD solutions for 6 months. The primary study's objective is to demonstrate non-inferiority of Silacor in terms of kJ/urea, which is a measure of adequacy, for which a clinically acceptable non-inferiority margin of -2.25 has been determined. So hopefully in the next year, we'll have something else to be able to offer to our patients. And now lastly, before we finish, I do want to mention some other things that are not the entire substitution or creation of a new solution, but rather addition of membrane cytoprotective compounds or osmometabolic agents to PD solutions. In interest of time, I'll just mention alanoglutamine, sulodexide. We just supplement the patients with these agents, and apparently in labs, it's been shown that it reduces fibrosis and inflammation. And now, interestingly, the gift that keeps on giving is SGLT2 inhibitors being looked at in PD as well. Obviously makes sense to use these. The rationale is we know we have proof that SGLT2 channels are expressed in the peritoneal mesothelial cells and fibroblasts. So it may mediate glucose uptake and downstream this damage, both locally and systemically. Like even in SH kidney disease, SGLT2 inhibitors may provide cardiovascular, metabolic, and possibly residual renal function benefits, though their glycosuric effect is minimal when GFR is very low. Current data are still very small scale, preliminary, mostly from animal models and pilot human studies, but it's promising. Larger RCTs, however, are needed before they can be considered standard of care in PD management. This is just a busy slide, but showing you everything, like I mentioned, touched on the previous slide, where we are with these things. A lot of them are limited by the fact that they may be excreted renally. So many of these are still not proven to be safe in the long term. And then finally, to conclude and be open for questions, the efficiency of peritoneal dialysis relies on the integrity of the peritoneal membrane. 20% of the peritoneal solid transfer rate is genetically determined. Ultrafiltration is directly linked to survival. We practice by trying to avoid high glucose containing dialysis fluids. Peritoneal rest works. Angiotensin II blockade is important, as is the preservation of residual renal function, and we help ourselves with high dose diuretics. Use of non-glucose based solutions, and addition of protective compounds and or osmometabolic agents. So with that, I conclude my talk. Thank you for your attention, and I'm open for questions.
Thank you, Dr. Dejman, for that beautiful review. We appreciate it very much. Before I open up the floor to questions, let me ask you one. Is there any contraindication to starting PD and then going to HD, or HD then going to PD? And what about patients that are candidates for renal transplantation? Does peritoneal dialysis preclude consideration?
Great questions. So when a patient chooses and hopefully is educated on their options, they're never married to a modality. They can go from PD to hemo or hemo to PD, whatever suits them the best, we will adapt. And then to answer your second question, no, being on peritoneal dialysis does not preclude the patient for transplant. In fact, it's been shown that they do better after transplant in terms of outcomes.
Do better on PD first?
Yes, PD first and then transplant, they do better in comparison to patients that were previously on in-center hemo.
And can you comment on the economics of one versus the other?
Absolutely. It's like I mentioned, the cost effectiveness favors peritoneal dialysis versus in-center hemodialysis. Per patient per year, the cost of PD is around $80,000, while in-center hemodialysis is almost $100,000, without considering the costs of hospitalizations, which we know, and you probably see it in the wards, more in-center hemo patients go into the hospital in comparison to PD patients.
And who inserts the PD catheters?
Also a great question. I forgot to mention that. Here in our institution, we rely on surgeons. However, in other institutions, interventional radiologists and nephrologists are also doing
Nephrologists.
interventional nephrologists.
Interventional nephrology. Okay, any questions from the audience?
Hey, Dr. Dejman, thank you for the lecture. Great review. Appreciate that. You mentioned the genetic studies. Do you think in the long term, in the future, that is going to change the way we prescribe peritoneal dialysis?
Thank you for bringing up that point. It's not currently clinically available to check the patients for what type of genotype they have, but if it is developed, of course, I think it would help us at least choosing with what solutions start the patients on PD, like favoring icodextrin versus glucose-based if they're a TT for genotype, for example, but it's not commercially available to date.
Thank you so much, Dr. Dejman. We'll begin with our next speaker.
Dr. Durrani is an assistant professor of clinical medicine in the Division of Hematology at the University of Miami Myelodysplastic. Dr. Durrani is a board-certified hematologist-oncologist at Sylvester Comprehensive Cancer Center. He earned his medical degree from the Aga Khan University Hospital in Pakistan and completed his internal medicine residency at Jefferson Abington Hospital, later completing his experimental therapeutics fellowship at the Cleveland Clinic and hematology oncology fellowship at the National Institute of Health, or NIH. He also completed an advanced fellowship in bone marrow failure syndromes at the National Heart, Lung, and Blood Institute, or NHLBI. His research includes aplastic anemia, immune-mediated cytopenias, paroxysmal nocturnal hemoglobinuria, large granular lymphocytic leukemia, inherited causes of bone marrow failure syndromes, clonal hematopoiesis of indeterminate potential, or CHIP, clonal cytopenias of undetermined significance, inherited genetic variants that predispose individuals to myelodysplastic syndromes and VEXAS syndrome. It's my great pleasure to introduce Dr. Durrani for his fascinating talk on DNA repair alterations and MDS.
Thank you so much for that very kind introduction. Give me 1 second. All right, good afternoon. It's always nice to have a full room. As she was mentioning, I think the talk here today, this case that I'm going to be sharing is about it really highlights the importance of genetic testing in something that's myeloid driven and MDS. This is not moving.
Use the keyboard arrow.
That's no. Now it's done. There we go. So this slide really outlines the objectives of the talk today, to understand the role of genetic predisposition and bone marrow failure syndromes in the evolution to myeloid neoplasia, to apply the MDS prognostic subgroup classification to guide risk-adapted therapy, and to develop risk-based treatment approaches for patients with a Fanconi type phenotype. So our patient was a very nice 36-year-old Haitian female who presented with or was diagnosed with early onset myelodysplastic syndrome. She was referred to the University of Miami for a transplant evaluation and a second opinion for her delayed count recovery after exposure to chemotherapy. She had a lifelong history of anemia, for which she had never been given a diagnosis before. In June of 2024, she was also diagnosed with genital warts and low-grade squamous intraepithelial lesions. The diagnosis of MDS came in September of 2024, based on a bone marrow biopsy that showed cellularity, increased cellularity of 10 to 60%, blast of less than 5%, but with dysplasia that was greater than 10% in all 3 cell lines. She also had a MECOM gain positive present and a karyotype with 2 karyotypic abnormalities. At the time, she also had a genetic test, and there was a limited panel for some 5 genes that did not show any myeloid driver mutations. But what I mean by myeloid driver mutations is mutations that maybe have been clearly associated with causing the disease or causing the progression of the disease. Physical examination and family history were unremarkable for her. So myelodysplastic syndromes are a heterogeneous group of clonal hematopoietic stem cell disorders characterized by ineffective hematopoiesis, dysplasia in greater than 1 line, hypercellularity of the bone marrow, and there's a risk progression associated with acute leukemia development in 20 to 30% of the cases. Driver mutations are central to the disease initiation and progression, and these can range from either epigenetic modifiers or transcription factors from TET2 to TP53 mutations. It's very important to understand these driver mutations for diagnosis, prognosis, therapeutic decision-making, and risk stratification in MDS. Risk stratification is usually done using IPSS-R, or IPSS-M, which is the more recent version, which takes into account the molecular or genetic mutations. Another thing that was positive for our patient was MECOM, which is the MDS1 or EV1 complex locus. This is an oncogene, and its overexpression or gain is strongly associated with adverse biology in myeloid neoplasia. The treatment options for MDS are really dependent on if this is a high-risk MDS or low-risk MDS. For high-risk MDS, pointed out in red over here, the goal of treatment is to reduce the disease burden. But for low-risk MDS, the target or the goal is to improve the quality of life and to provide supportive care. In high-risk MDS, we utilize hypomethylating agents, which is chemotherapeutic agents that target the disease. But for low-risk MDS, we provide supportive care by providing erythropoiesis-stimulating agents that can help improve anemia, which is the most common cytopenia in low-risk MDS. Some of the medications that have been approved in the use of low-risk MDS are in patients that have the deletion 5q specific MDS, lenalidomide. For the non-deletion 5q MDS, there's erythropoietin-stimulating agents, which were historically used in the past, and the more recently approved luspatercept, which was approved in August of 2023. I'll come to the mechanism of action of luspatercept later in this talk. So our patient was diagnosed with high-risk MDS based on the IPSS-R and M, and she started getting azacitidine starting beginning of October 2024. She got 3 cycles, all with slow count recovery afterwards. Also, interestingly, when she was exposed to azacitidine, she immediately suffered from amenorrhea. So there were two clinical questions over here that we had to answer. One was to investigate the cause for the delayed count recovery, and second was to assess for the need for a bone marrow transplant over here. You can see on the table on the right, the purple arrow marks where azacitidine was introduced, and you can see the hemoglobin is persistently remains low after the exposure to azacitidine. To understand the effects of azacitidine on the bone marrow, it is essential when we consider hematological recovery in these patients. The azacitidine is a hypomethylating agent that mimics natural DNA and RNA building blocks. When built into the RNA, it disrupts protein production, and when built into the DNA, it blocks the enzymes responsible for silencing genes. That means that abnormal DNA methylation is removed and the body's natural safety genes can turn back on. As a result, abnormal blood cells either stop growing, mature properly, or just simply die off. Standard dosing is 5 to 7 days every 28 days. And usually count recovery is expected by the start of the next cycle, which is approximately 28 days. The nadir counts are mostly seen in the second week of treatment. The clinical concern over here in this case was that both of her cycle 2 and 3 were delayed by almost 3 to 3.5 weeks, which is very unusual in a young patient and also somebody who just started treatment. So going back to our case, let's walk through the red herrings over here. First, young age, which is unusual since MDS typically presents in older patients. Second, the lifelong anemia, which raises the concern for a constitutional cause. Third, the presence of genital warts and the HPV infection, which point towards immunodeficiency or DNA repair defects. Fourth, the delayed count recovery with azacitidine in this young patient who was just starting off with treatment, and the abrupt cessation of menstruation after the exposure to hypomethylating agents. To better understand the underlying pathophysiology, we looked into obtaining an inherited genetic test panel. Interestingly, this had been done previously by the outside physician who had referred the patient to us. However, this had been mostly considered negative because even though the patient had mutation in Fanconi A gene, but these were two separate mutations, not homozygous. They were two heterozygous mutations, both considered and listed as pathogenic, but not biallelic. So given the atypical picture that this patient had, we still went ahead and tested her with the diaboxybutane chromosomal breakage test, and indeed this was positive. The DEB test works by cross-linking DNA. In normal cells, this causes minimal breakage, but in Fanconi anemia cells, defective DNA repair leads to increased chromosomal breaks and rearrangements. We measured the number of breaks over here, and the high break rate means a diagnosis of Fanconi anemia. This is the gold standard for the diagnosis of Fanconi anemia, and it also helps with differentiating Fanconi anemia for other bone marrow diseases. And it can be used to test at-risk family members as well. So then we moved forward to getting a repeat bone marrow biopsy to confirm the diagnosis. And again, a hypercellularity was seen. Blast count was a little bit more reduced this time, but then she'd been exposed to 3 cycles of azacitidine as well. But dysplasia persisted in greater than 10% of the cells. We also got a genetic test done, which persistently showed the Fanconi A gene mutations, again, heterozygous in 2 different genes. The amenorrhea was diagnosed as a premature ovarian failure in this patient, unfortunately. Based on the information and data we had, we suspected that she had bone marrow failure with subsequent evolution to MDS. To understand the impact of pathogenic inherited or germline predisposition genes, we have to revisit some of the data. In 2016, WHO classification introduced a novel category of myeloid neoplasms, which with germline predisposition, such as GATA2, DDX41, and RUNX1, amongst other genes. Usually, germline mutations are disease-causing when inherited as autosomal dominant, or biallelic mutations when heterozygous recessive genes. Multiple heterozygous recessive alterations may be predisposing in carrier status if loss of function is seen in both genes. And this really highlights the importance of comprehensive genetic and inherited genetic testing as well for all patients with early diagnosis of MDS. especially with those that have physical phenotype that might be concerning, comorbid conditions, or strong family history. Please make a note of this is that there is no mention of compound heterozygous mutations, which means that mutations that not only are heterozygous, but there may be more than one and may be placed at different sites, either on the same allele or a different allele. And again, this is a rare presentation. A 2021 leukemia study examined how incidence and age of onset vary by causal gene. Figure A on the left shows the incidence of MDS in blue and another bone marrow failure disease, aplastic anemia, in the red, across ages from 0 to 75. Figure B illustrates the age of onset by gene, showing early childhood pathogenic variants and mutations in genes such as SAMP9 and 9L, predominantly 20s to 30s for DNA repeated gene variants, as was seen in our patient, and older ages for DDX41 variants. To better understand the cause of MDS in our patient, we really have to dive back and revisit the cause of most common inherited bone marrow failure syndromes, Fanconi anemia, which in 90% of the cases is caused by a biallelic, meaning both genes involve mutations in Fanconi A, C, or G gene. Over the time and over the years, the Fanconi pathway now includes a total of 22 different genes, but these are the ones that are mostly seen in 90% of the cases of Fanconi anemia diagnosis. The disease shows incomplete penetrance and a wide spectrum of clinical features. Functionally, Fanconi anemia plays a key role in sensing and repairing DNA interstrands, cross-linking, and managing replication stress. The biallelic Fanconi variants cause roughly a 75% reduction of function, while heterozygous variants reduce function by 35 to 45% only. Again, this data is for single heterozygous mutations, not compound heterozygous mutations. But you can see that the difference between biallelic and heterozygous mutations and the degree of loss of function over here. Carriers may have a high risk of solid tumor and inability to function properly when exposed to increased genotoxic stressors. In adults, genetic risk for MDS is harder to detect due to rare presentations, but Fanconi gene alterations, especially in compound heterozygous states, can increase the risk of adult myeloid neoplasia. In the study of studying a cohort of 3,000 adults with bone marrow failure or myeloid neoplasm, including 2,600 patients with myeloid neoplasia, germline genetics were analyzed for their impact on disease. And up to 10% in bone marrow failure and 5% in myeloid neoplasia cases carried germline variants. Additionally, 1 to 1.5% of the cases had multiple germline variants in functionally related genes. The investigator also showed an increased incidence of Fanconi pathway alterations reported in both myeloid neoplasia and bone marrow failure. When they further looked into assessing for the overall survival using Kaplan-Meier curves, you can see that the survival was definitely lower and statistically significant in those patients that carried a pathogenic or likely pathogenic variant compared to those that did not have any. When they looked at the autosomal dominant genes, the statistical significance remained there. However, when they looked at the autosomal recessive genes, the numerical difference remains there, but the statistical significance was lost. Just keep in mind over here that, again, heterozygous mutations were studied as singular mutations and not compound heterozygous multiple mutations over here. Disease-specific frequencies of pathogenic variants are increasingly being reported. And in myeloid malignancy cases, about 5 to 15% of the patients may be carrying these germline genetic variants or inherited variants. So we suspected that based on the data that our patient had either one or both genetic hits leading to a loss of function. We suspected that this may have been either that she was born with both mutations or may have acquired a secondary mutation that led to a biallelic loss of function, causing functional deficiency and Fanconi anemia-like phenotype, not true Fanconi anemia, but Fanconi anemia-like phenotype that led to bone marrow failure, clonal evolution, and for the development of myelodysplastic syndrome. Management of MDS, evolving from bone marrow failure due to Fanconi anemia differs from a typical MDS. And despite low blast count of about 2% in our patients, for example, the presence of abnormal karyotype and the MECOM and the presence of severe marrow failure warrants the evaluation for hematopoietic stem cell transplant in these patients. Particularly in MDS, where the blast count is less than 10, the recommendations are the classical approach to reduced intensity hematopoietic stem cell transplant without exposure to high intensity chemotherapy. There we go. Even with stem cell transplant, long-term outcomes remain poor, mainly due to GVHD and treatment-related complications. However, we know that the patients in complete remission before hematopoietic stem cell transplant and younger patients have significantly better survival than those transplanted with active disease. And this is why we felt that for our patients specifically, it would be important to take her to transplant now when she had disease control with the blast count less than 2%. And given that her age was still 36 and she was young, we felt that it would be important to offer her definitive treatment. However, aware of the anticipated time delay between when she could be completely worked up and a donor could be, we could search for a donor. What do we do between this time for our patient? And we decided that maybe offering her something like luspatercept may be reasonable. Luspatercept works by binding to the TGF-beta superfamily ligand, reducing SMAD2 and 3, and eventually promotes a late-stage erythroid maturation. This helps increase the blood cell production in patients with anemia. The FDA approval was for low-risk MDS based on the COMMANDS phase 3 trial, which showed particularly that in cases of patients that had low-risk MDS and had erythropoietin levels of greater than 500, that the use was superior in achieving the primary outcome or the endpoint, which was transfusion independence within 12 weeks compared to erythropoietin support alone. This table shows the timeline for our patient where she was exposed to azacitidine between the start of October 2024 and when she started the luspatercept in February of 2025. You can see that the hemoglobin remains low persistently after the exposure to azacitidine. Neutrophils also remain low. However, when we started luspatercept, her hemoglobin started improving by a total of 2 grams from 8.7 to 10.6. But as expected, her neutrophil count was not responsive to treatment, and she still needs definitive treatment with stem cell transplant as she's being worked up. But at least we were able to bridge her anemia and provide some improvement. The goal for our patients' next goals are that we referred it to for genetic testing. We will be doing a fibroblast testing for patients that are suspected to be born with germline or inherited diseases. We think that fibroblast is better than getting a blood test, which was done previously for her. The reason is because if the blood, it's a dynamic tissue, changes over time. You can acquire a mutation, and that mutation can start showing up in the blood as well. But a fibroblast will tell you if they were truly born with these 2 different mutations, or if she acquired one after or over time during her aging. Fertility preservation, unfortunately, because she has premature ovarian failure, we were unable to harvest any eggs, but this is something that's very important for patients going towards transplant and or patients that have Fanconi anemia. Bridging therapy for her that we offered was luspatercept. Is there a role for the traditional danazol treatment that is used in bone marrow failures? Yes, but we would not stop treatment with that is already showing improvement in anemia to offer danazol. It is something that we have at the back of our mind if in case the patient needs any. Transplant planning is underway for this patient. However, this is a challenging case because not only is she has a germline genetic mutation, possibly, family members may not be suitable candidates given that they may share this mutation. And also given that she is Haitian, the registry does not have a lot of donors available from certain ethnicities. Cancer surveillance becomes important in these patients with Fanconi anemia. And even though we don't know really where our patient will land in case of, for the strategy, because she's not true Fanconi anemia, but a Fanconi-like phenotype. But we're going to adapt to what we usually do for our Fanconi anemia patients, which is cancer screening every 6 months with head and neck, skin, and genital, and keep an eye out for multiple primaries for a patient like this. Excuse me. The key points here are that suspect germline predisposition in early onset MDS, bone marrow biopsy, and mutational analysis are essential for accurate risk prognostication. Particularly in this case, it's important that when you have a patient that's young and develops MDS, it might be important to do germline genetic testing in addition to the somatic, which is acquisition of mutations, those mutations that may have been acquired over time during their life. Confirm germline syndromes in collaboration with your geneticist colleagues, especially for compound heterozygous mutations and their clinical impact. Discuss prognosis with patient and implications for family members. Management is highly individualized, and allogeneic stem cell transplant remain the only curative option. But the timing of the transplant and the induction or the treatment that needs to be given before becomes highly something that needs to be discussed with your transplant colleagues. And while luspatercept will be used in this patient, it's far from ready for this use. This will require further study. With that, I end my talk, and thank you for the support by my mentors and the Department of Medicine, leukemia section, hematology, and our transplant and our translation genetic colleagues. Thank you.
Thank you very much. Well, maybe we have a few questions. Thank you for that very interesting presentation. So, you intrigued me a little bit when you said that the best tissue perhaps to do the genetics on is the skin fibroblast, but there can be, as opposed to perhaps a more dynamic peripheral blood. But why choose specifically the skin fibroblast, why not epithelial cells from the lining of the mouth? Because they can all have different expression perhaps of these different genes. So that's one question. The other one is, would you recommend, or did you recommend in the siblings of this patient that they undergo genetic analysis as well?
So the answer to the first question is that basically the choice of fibroblasts is something of a historical background. Fibroblasts you can obtain in culture and grow, and that gives you more DNA tissue to examine. However, that being said, there are studies that are looking at even nail clippings and getting tissue from there to do genetic testing, germline genetic testing. So I think over time this might change, but this is the one that I prefer right now, is because we get so much DNA with cultured tissue that the chances of missing a mutation is likely. The second part is that, yes, I think that's a very important point, as I mentioned, that the family members have to be counseled. It's a little tricky because sometimes people don't always want to know the answer if they are not showing or exhibiting the disease, but it's an important conversation to have. I usually rely on our geneticist friends, colleagues to have part of this conversation and offer these testing after they've been through my clinic and I've offered it to them. And usually these should be tested. And for our patient, it was also interesting because she only had half siblings. So even when we do her, like the siblings are going to be tested, we're not going to know if she actually acquired the second mutation from her other parent, or if she developed it from over time, or if she just inherited both from her the same parent. So that's going to be a little tricky, but I think they were still going to get that genetic testing done. Thank you.
Yeah, and one other question, since someone seems to be raising their hand. What's really scary here is the fact that she had this anemia for many years before she was actually diagnosed. I wonder, did any of her other half siblings, how often do we aggressively work up in a menstruating woman at the time, a hemoglobin of 8 or 9? We should, but how often are these sorts of things likely to result in such a diagnosis? In other words, how rare?
I think the question of rare is a very interesting one, right? Because it is a biased one based on reporting and testing. I think we're becoming more, we're acquiring the skill of doing this more frequently and sooner than we used to. But most of the patients that are menstruating have low hemoglobin. This is chalked up to menorrhagia. But I think that it is important that we start adapting the strategy, working them out more
Aggressive.
yeah.
Thank you.
Thank you.
Dr. Zekaris.
Jibran, that was terrific. Any considerations for the conditioning regimen that you would use for transplanting somebody with Fanconi anemia, given the breakage susceptibility?
Yeah, so specifically in this patient, where they are like patients like her, where the blast count is low, you can actually do reduced intensity without the exposure to intensive chemotherapy, because the concern is that if this is like a Fanconi anemia, true, like all tissue has this these mutations, then when you expose them to chemotherapy, the chances that they will develop a secondary malignancy is also high. The GVHD risk is high, and these become a compounding and confounding factors. For her, it will be the reduced intensity, because we would have to reduce the not only the chemotherapeutic exposure, but the exposure to radiation is also reduced to 1 to 300 diopters higher in patients who have more aggressive leukemias in the background.
We usually give fludarabine with reduced doses of cyclophosphamide plus minus ATG. Hopkins for haploidentical gives a dose of TBI also, but only 2 to 3 grades.
Did you understand the question? Was there a question or just a comment?
He was adding the
just
conditioning regimen. That was
comment.
last.
Yeah, the question is
last.
if you check for GATA2 deficiency because of the genital warts for so long time, and because GATA2 deficiency is also it can also give myelodysplastic syndrome and bone marrow failure syndrome.
Absolutely, I think that's a very important point, and that's going to be tested as part of her germline genetic testing. Though she does not exhibit the other signs with GATA2 deficiency, they're a lot more sicker constitutionally than what she looked like. She had a normal phenotype. The only thing that was abnormal was her essentially the bone marrow that was not functioning properly anymore.
Okay, last question.
Thank you, Dr. Weiss. Thanks for the presentation. Right now you have a lot of nephrologists in the audience, and we normally treat dialysis patients with refractory anemias. We normally use high dose ESA, trying to achieve the hemoglobin goal. Most of the times we attribute that failure to inflammation, the use of tunnel catheters, etc. What is your recommendation? How we can screen those patients, and what is the best approach for them? Secondly, we do a lot of DNA sequencing analysis or testing in our CKD clinics, but we never test our dialysis patients. I was trying to see if any of the genes that we normally get reported in our Natera test are useful for the screening of myelodysplastic syndromes.
Thank you. Another great question. So it's a bit of a strategy and approach. The genetic testing, I'll give you an example, is that New Genomics tests 500 genes, but they give us the results for about 275 of them, even in the comprehensive panel. They mask the others, right? So within those new panels of 275, the Fanconi, I think about 18 of them are covered. So it's like there is an increasing incidence of including these genes, knowing what they could cause. However, there's a catch to this somatic myeloid panels as well. They test for mutations, or they report pathogenicity based on the pipelines for myeloid somatic, meaning those that were required afterward mutations. Sometimes they're not listed as pathogenic if they were germline. The suspicion index should be based on the VAF, or the variant allelic frequency that's listed over there. If anything above 35 to 50, then you start suspecting that this is germline and they were essentially born with this, since it's in all the cells there. And the clonality it's that either all of the cells have been replaced, or the fact that they were born with this and all the cells were initially had this mutation. In terms of the anemia, for the patients that have kidney disease, The concern again is that did they have this before they had the CKD? Now, obviously, there's going to be anemia because of chronic kidney disease as well, and anemia of chronic inflammation. So the suspicion index should also be based on the age of presentation. Was there something else going on in other family members or a phenotype as well? So.
Thank you for an excellent
Thank you.
presentation. Thank both our speakers. Now, this is our first grand rounds of the season. I want to thank everybody for coming in person. Isn't it nice and cozy? I promise next time we'll have actually more food, so you won't have to go out and look for it yourself. Next week, in lieu of grand rounds at noon, we're going to have the State of the Department address, which is also going to be hybrid at 5 p.m. over in the Lois Polk Center, and we'll resume here in 2 weeks' time. I want to remind everybody to check the QR code on exiting to get your MOC points of credit. And I wish everybody a wonderful and safe day, and thank you so much for participating in Grand Rounds.